Good morning, everyone. My case is a rare case of bilateral conjunctival capillary hemangioma. No financial interest. Consent of the patient was taken. A 21-year-old male patient presented to IOPD with a reddish mass over upper conjunctiva covering the upper cornea in both eyes. Patient complains that the mass has been gradually increasing in size over past few years. Patient complains of diffuse reddish, painless, non-tender mass over upper conjunctiva in both eyes, which his mother noticed 1 month after birth as a small reddish mass, which has been gradually increasing in size over past few years. Patient also complains of diminution of vision more in the right eye than in the left eye since childhood. No limitation or pain on eye movement, no difficulty in closing his eyes due to mass. Past medical history, surgical history, family history were all non-remarkable except for the treatment history where patient was taking some non-allopathic eye drops. General examination, patient was also very fine. Ocular examination, in right eye, we saw visual acuity, best corrected visual acuity of 2/60, and in the left eye, 6/9. In rest, everything was fine. In conjunctiva, we saw bright, reddish, soft vascular mass coming from upper pharyngeal conjunctiva and encroaching over upper cornea with small feeder vessels seen over the temporal side. Same findings was also seen in the left eye as well. Only thing is that the size of the mass was 17 to 10 mm in the right eye, and in the left eye it was 15 to 10 mm. In cornea, in both right eye as well as in the left eye, it was clear except for the reddish mass covering 1.5 mm of upper cornea. These are the photoslit lamp pictures of right eye and left eye. Ocular examination, extraocular movement in both right eye and left eye was full, free and painless. No pulsation seen, no bruit heard, but the mass glanced a little on pressure. Fundus finding in right eye we saw optic disc coloboma, and in the left eye we saw morning glory disc. We were suspecting some syndromic association in this patient, so we put patient on blood investigation. Everything was normal. In imaging study on ultrasound color Doppler was suggestive of bilateral capillary hemangioma. MRI brain and orbit was not very conclusive, though it showed increased anteroposterior diameter of bilateral orbit. No extension into the orbit was noticed. So we reached a provisional diagnosis of bilateral conjunctival capillary hemangioma, DD papilloma, cavernous hemangioma, and port wine stain. Management, we offered optical correction and medical management in the form of oral beta blockers. We started on oral propranolol with a low dose of 1 mg per kg per day after physician consultation. Topical beta blockers, systemic steroids, and topical steroid drops. Other treatment options available are intralesional steroids, immunomodulators, laser photocoagulation, carbon dioxide, argon, neodymium yak, and pulse dye lasers have all been utilized nowadays in the treatment of capillary hemangiomas. Radiation therapy, surgical excision, reserve where conservative management has failed or was suboptimal. Discussion, capillary hemangioma is the most common tumor of the orbit and periorbital area in childhood. Girls are more commonly affected than boys. Incidence of infantile hemangioma in general population is 5%. Capillary hemangioma is a hematoma composed of anastomosing small vascular channels without true encapsulation. Association are Maha, Kasabek-Marriott syndrome, Faces syndrome. Conclusion, my patient is a case of bilateral conjunctival capillary hemangioma with topical drops and oral beta blockers. Gradual decrease in congestion and size of the mass was noticed, though we were in diagnostic dilemma between hemangioma and papilloma as our imaging study was not very conclusive. So we tried mitomycin C as well, but the mass was responding more with beta blockers and steroids as compared to mitomycin C. These are my references. Thank you.
Go ahead.
So, any comments from your side? Can we just have the clinical picture of the patient, the conjunctival picture? Yeah. Excellent presentation.
Ma'am, we are
Congratulations.
still more in the suspecting. We were still in diagnostic dilemma between papilloma and hemangioma, but we are more in favor of hemangioma because patient is responding more with the beta blockers.
Yeah. Can we just have the picture? I mean, just to take you through. Yeah. Right, yeah. I'm not sure, hemangiomas are usually really vascular and reddish, right? Yeah. And with the Morning Glory Association, so many things, you know, something that I would keep as a differential diagnosis here would be a complex choristoma.
Choriostoma.
Yeah, complex choristoma, which could be reddish if there is a lacrimal gland. Dr. Biswas would be the best person to talk about it. So that's what I would actually keep in mind. When you told me that beta blocker, there is a response. Do we have a post beta blocker picture? How much it has responded?
Did not came for follow-up.
Right. So this is the first thing that I would keep in my mind when I see this, you know, bilateral, and then with disc anomalies and many other things going on in the child.
Yes,
So
we haven't seen
Bilateral
such
capillary anemia is very unusual.
Yeah, ma'am, we haven't seen such cases anywhere.
yeah, one thing you could have done is you could have done a biopsy, and you know, it's excisable if you put an AMG there, and you know, so you get a diagnosis. It also becomes a treatment, you know, right? It's surgically excisable. I think so, right? I don't know what the posterior extent is, but I feel so. I don't know.
Patient was also not willing for to undergo any surgical
Surgery,
procedure.
yeah.
We were consulting him, but he didn't showed up also.
Right. So choristoma is something that I would keep in mind. Thank you.
I think there is some publication of having a bilateral disc coloboma with choroidal coloboma and orbital hemangioma. So they are also in the conclusion, I think one of our friend Fasad's publication. So there are also conclusion that it can be syndromic, and that is what they have concluded. So this is very nice. You are getting, it's very rare, as sir has already mentioned, bilateral hemangioma, but Farsad's paper also says the same thing. So you should publish this. Provided you can prove it, it is a hemangioma. You need to prove it.
Yes, ma'am. Ultrasound was also suggested.
Ultrasound is not.
But it was not very reliable. We should be going for the. Yes.
Make you publish.
But you do a biopsy.
Okay, ma'am. But patient didn't follow. Came for the follow. We were planning to.
You know, loss to follow-up in this generation cannot be accepted, because every patient, when I see people from very low socioeconomic status, also they have a phone. Even the laborers who work, they have a phone, no? So
Mobile,
that mobile. So that tracking the mobile number and having the correct number is very important, you know, especially old generation. No, in your time, loss to follow-up can be, accepted. In our generation, it is okay. But the young, I always tell my students also, you cannot say that we are not. You have to follow the patient. You have to take multiple mobiles number. Like if you have something, a rare disease like this, okay?